Polycystic ovarian syndrome is a diverse and complex female endocrine disorder, a global phenomenon that affects more than 10% of the women of reproductive age. Lifestyle and genetic factors have contributed to the dramatic upsurge in the prevalence of PCOS, which has increased significantly in the past 10 to 15 years. The emergence is attributed to obesity, stress, genetic predisposition, and compromised lifestyle. Clinically, PCOS manifests through menstrual disturbances, acne, hirsutism, infertility, and obesity. PCOS emanates from the vicious circle of insulin resistance, androgen excess, and anovulation. Insulin resistance is intrinsic to PCOS and is the major contributor to its pathogenesis. Insulin's resistance affects both liver and other peripheral tissues, like muscle and adipose tissues. At liver, insulin resistance mediates through increased gluconeogenesis and increased lipid synthesis. At the peripheral tissues, muscle and adipose, insulin resistance causes reduced uptake of glucose from the blood. At adipose, there is increased lipolysis, leading to increased free fatty acids in the blood that activate gluconeogenesis. Both the hepatic and peripheral aspects of insulin resistance lead to increased levels of glucose in the blood. To compensate for increased blood glucose, the pancreas secretes more of insulin. Hence, insulin resistance through hepatic and peripheral aspects lead to hyperinsulinemia. The increased circulating insulin levels at liver reduce the sex hormone binding globulin concentrations, or SHBG. Reduction in sex hormone binding globulin concentration leads to increase in free circulating testosterone levels. At the pituitary, the elevated level of circulating insulin increases the luteinizing hormone pulse frequency and amplitude. Increased luteinizing hormone in turn leads to increase in androgen production in the ovary. Thus, insulin resistance and compensatory hyperinsulinemia lead to hyperandrogenemia. The excess androgens that occur in the body impair folliculogenesis, or the maturation of follicles, resulting in menstrual disturbances and development of multiple ovarian cysts in the ovary. In such a condition, inducing ovulation without controlling the high androgen levels can lead to egg aneuploidy, spontaneous or recurrent abortions. The excess androgen levels in women with PCOS also lead to acne. It also leads to male pattern hair growth called hirsutism. Using an insulin sensitizing agent that predominantly works at either the hepatic or the peripheral aspect will not take care of insulin resistance completely. Launching for the first time in India, a comprehensive solution to treat insulin resistance, Metital. Metformin is well-researched, documented, and safe insulin sensitizing agent that reduces hepatic glucose and lipid production. Metital, an inositol derivative which acts as second messenger in the insulin signaling pathway that increases the peripheral glucose uptake. In Metital, metformin activates the enzyme 5-AMP-activated protein kinase, or AMPK, and thus inhibits hepatic gluconeogenesis and lipid synthesis, thus controlling insulin resistance at the hepatic level. Myoinositol in Metital increases the glucose uptake in muscles and adipose through GLUT4 translocation by activating the PI3K AKT insulin signaling pathway, controlling the insulin resistance at the peripheral levels. Metital, a comprehensive solution to treat insulin resistance, also has a significant role in correcting ovarian dysfunction due to insulin resistance. Metformin in Metital inhibits the activity of enzymes CYP17 in the theca cells and steroidogenic acute regulatory protein 3-beta-hydroxy dehydrogenase in granular cells, thereby reducing the ovarian androgen synthesis, increases the ovarian antioxidants, reduces the anti-Mullerian hormone levels, improves menstrual abnormalities and resumption of ovulation. Myo-inositol in Metital improves the ovulatory function, increases the oocyte quality and improves oocyte maturation. Metital, a comprehensive solution to treat insulin resistance. A comprehensive combination of metformin and myo-inositol to control insulin resistance. Metformin predominantly controls hepatic gluconeogenesis and lipogenesis. Myo-inositol increases the glucose uptake in muscle and adipose tissues. Metformin and myo-inositol also correct the ovarian dysfunction caused due to insulin resistance. Metital, a comprehensive solution to treat insulin resistance, a boon for PCOS patients.